Good afternoon, and welcome to today's AFTD Healthcare Professional webinar, Speech Language Therapy, a Promising Practice in FTD Treatment and Care. I am Will Reiter, the Education Program Manager at the AFTD, the Association for Frontotemporal Degeneration, and I'm very excited that we are bringing this program to you today. We will get to that momentarily, but first, just a few quick announcements. You should know that we have muted our audience, but AFTD staff are standing by to assist you if you encounter a technical issue. So if that happens, let us know directly by writing a message into the Q&A box. Second, time permitting, we will conduct a brief Q&A segment at the end of the presentation. If you want to submit a question anonymously, just click the box to the left of the send button, and you can submit those questions at any point. We'll be reviewing them and curating them and asking them during the Q&A time period. And then finally, this webinar will be recorded and archived for later viewing at AFTD's YouTube page and in the webinar section of our website. And speaking of our website, this is a screenshot of our dedicated healthcare professionals webpage. This section includes an archive of all of our healthcare professional webinars. It also has a library of our e-publication Partners in FTD Care, which is specifically targeted to healthcare professionals. New issues for that e-newsletter come out every other month. To get those newsletters in your inbox or get invites to our other healthcare professional opportunities, you can also sign up on this page to join our healthcare professionals mail list. You may be joining us today not only to watch and learn, but also to obtain continuing credit. To do that tomorrow, check your email. We'll be sending you an email that describes how you can complete an evaluation and submit for credit through Rush University. Know that you have up to 10 days from the date of the activity to complete the evaluation and claim your credit. Please check your spam folder tomorrow if you don't immediately see it. Sometimes it ends up there before contacting us if you feel you've not received that email. So this is a listing of the learning objectives for today's program. They were listed on the promotion and also the registration, so I won't take the time to walk us through them. And now I'm going to move on to introducing you to our speakers for today's program. So first off will be Becky Kayum, who is a speech-language pathologist specializing in care for people living with different types of dementia, including primary progressive aphasia. She's the president of the therapy company Memory and Aphasia Care and is the co-founder of Cognitive Concierge. Becky is also co-chair of the PPA task force at the National Aphasia Center. Next, we'll hear from Dr. Anna Volkmer, a senior research fellow at University College London in the United Kingdom. She is also a consultant speech and language therapist at the National Hospital for Neurology and Neurosurgery in London. And she's worked clinically with people with dementia and their families for nearly 25 years and has been a writer or collaborator for numerous peer-reviewed journal articles and books. And then finally, our last presenter will be Dr. Stephanie M. Grasso, She directs the Multilingual Aphasia and Dementia Research Lab at the University of Texas at Austin. She's worked primarily with historically underserved populations to address health disparities. Her work aims to establish the efficacy of treatment approaches for bilingual adults with aphasia and investigates variability in treatment responsiveness and examines bilingualism as a contributor to cognitive reserve. Again, we'll hear from all of our presenters, and then we'll have questions at the end. So at this time, I'd like to welcome our first presenter, Becky Kayum, to the stage. And there she is.
All right. Well, it's so good to be here with everyone. Thank you again for to the AFTD for inviting us to speak today. I'm just going to share my screen. Let's- All right. Here we go. Okay, so I'll just move forward here with our disclosures. Okay, so here's today's agenda. So we're going to start out with just an overview of what is the speech language pathologist or SLP's role in evaluating and providing person-centered treatment for people living with primary progressive aphasia, PPA, and primary progressive apraxia of speech, PPAOS. I'll provide a quick case example of a treatment goal and participation focused interventions to support that goal. Anna will be talking about conversation training for people living with PPA and their communication partners. And then Stephanie will be talking about assessment and treatment considerations for bilingual individuals with PPA. So I always like to start with just talking about what we're going to be focusing on today in terms of the type of frontotemporal dementia. There are three kind of main categories as I like to think about FTD just based upon the initial symptoms a person experiences. And today we are going to be focusing on those whose initial symptoms are language or speech changes, so which would be PPA and PPAOS. While speech language pathologists can certainly help with symptoms related to personality, behavior, and movement disorders, today is just going to focus on those language and speech changes. So I always like to also just remind everyone what is the scope of practice for speech language pathologists. And so it really does encompass a lot of areas, cognitive communication disorders, language disorders, of course, including aphasia, motor speech disorders, which includes that apraxia of speech. We work with people who have voice disorders, swallowing disorders or dysphagia, and certainly some education and counseling as related to people's cognitive communication and difficulties. So, what is the role of the speech language pathologist in terms of diagnosing PPA or PPAOS? And so, in some settings, the SLP will participate on that interdisciplinary team, with neurology, neuropsychology, perhaps psychiatry, and we can contribute to a consensus diagnosis. This isn't always the case. Certainly, it's the neurologist who typically makes that official diagnosis, but we may contribute to that diagnostic process. But I think today what we're really going to focus upon is what is the purpose in terms of an evaluation to develop a treatment plan? So, not diagnosing. And really, SLPs have to consider additional assessment tools to supplement the diagnostic testing that the person has likely already received. So, those could be a motivational interview, and Stephanie's going to talk a little bit about those ethnographic considerations in that interview. Using patient reported outcome measures, we do some collaborative goal formation, and then from that process, really thinking about our person centered participation focused goals. So, a really nice framework for thinking about how do we develop those person-centered goals in our assessment is AFROM, so living with aphasia, a framework for outcome measurement. And so it's thinking about if someone's living with aphasia or apraxia of speech, progressive, certainly in this case, not just focusing on the impairments. So how do those impairments impact their participation in life situations, their communication environment, their communication social network, their identity and feelings, and also, certainly that is also that life participation approach to aphasia is that term that's commonly used. And for SLPs, a great resource is Aphasia Access, which is an organization that does help to train SLPs in applying this approach, including to people living with PPA or PPAOS. So let's take a step back for a moment before we talk about intervention and what is the treatment philosophy in terms of people who are living with PPA versus stroke induced aphasia. So progressive aphasia versus stroke induced aphasia. And so, first of all, we're thinking about those gradual onset of symptoms. So, with a stroke, I can speak pretty easily today, and now I have my stroke, and tomorrow it's very difficult for me to speak. With that gradual onset of symptoms, aphasic symptoms, the individual and their family members have already had a chance to really develop some of their own communication strategies over time. So it's really important for SLPs to take that into consideration during their evaluation. A lot of times we're thinking about the preemptive introduction of compensatory strategies, so using alternative augmentative communication maybe before it's actually needed. We're certainly going to be modifying those communication strategies and increasing that level of communication partner support over time. There are the emergence of non language cognitive symptoms over time, so certainly having to develop goals that focus upon those symptoms as well. With someone who's living with a stroke, we're really trying to reintegrate them into society and their social network over time. Whereas with PPA or PPAOS, we're trying to prevent that social withdrawal as the condition progresses. Certainly, we're providing that ongoing speech language therapy at regular intervals throughout the progression. And also, I think what's so tough for many healthcare professionals, certainly working with a progressive diagnosis, is that disease education and counseling. How do I know what to expect about the future? The symptoms, obviously are worsening rather than improving over time. How do you talk to families about that? And that will certainly look different. So now let's move on to interventions. So we've established our person-centered goals. We've worked with the individual and their family members to figure out what's the most important to them. And so there are different kind of categories of types of interventions we might use to support those goals. And so the first is what we call restitutive interventions. And those really focus upon rebuilding lost communication skills. So there is some promising research in terms of if we do specific exercises that might help the individual practice word finding or speaking at more the sentence or level, or perhaps grammar and fluency and comprehension of words. Can we improve those? And that certainly is on an ongoing field of study, but the results are promising so far. And our focus is, can we target words and conversation topics that are important to that individual so we can generalize those to daily conversations? So that's that first category. The second is compensatory interventions. So, what we're doing with those is we're really bypassing those speech and language deficits to facilitate their ability to participate in conversation and life activities. So, that might include things like environmental modifications. How do we set up the environment for communication success? Certainly using those AAC supports. And Anna's going to be talking a lot about conversation training and what we can do to help train the individual and care partners in that at that conversation level. So, in terms of how do we kind of combine these different kind of types of interventions, it really is a unique combination for each person living with the diagnosis and their communication partners. Um, and so that is really important to remember in terms of every person's going to be different. And also, that combination is probably going to change over time. And there's certainly systematic reviews that have been conducted that look at restitutive and compensatory interventions and what the research is showing so far. Anna is going to be covering this quite a bit in terms of communication partners, and it is important to try to involve communication partners throughout the assessment and treatment process because they're going to be a critical team member. Especially as the individual has more and more difficulty with communication, other cognitive skills over time. So that's really important in the SLP evaluation and treatment. So let's kind of put it all together in terms of talking about let's just do an example of a participation focused goal. And so let's say this individual's goal is, I would like to talk more about my garden with my children, with my friends, because this is a hobby that's really important to this individual. So what might we do to help support that goal with evidence-based interventions? And again, that holistic approach to treatment. So when SLPs are thinking about creating different types of restitutive speech and language exercises, where there are many different types of exercises that have been studied in the research. I'm certainly not going to go into all of that today, but we're thinking both about their profile of strengths and weaknesses. And we certainly do look at that PPA variant or subtype and think about how that might contribute as well in terms of developing those speech and language exercises, again, that are targeting words, phrases, conversations that are important to people in daily life. And then certainly let's talk about some examples of compensatory strategies that we might use. So of course that conversation training, talking about gardening and working on that, Anna will speak more about that in a moment. But let's think about some visual and graphic communication aids. So what might we do? And I'm just going to give you some examples of what would gardening scripts for conversations for practice look like. Perhaps the individual has a garden and they can place little signs in the garden on little posts that list the flowers and plants names if they're showing people around their garden or taking pictures of it. We can certainly create a gardening section with pictures and phrases or a script in their communication book or wallet that they can use. Reminiscence certainly is so important. So creating a tab for that in perhaps a communication aid. And then I think we always get a lot of questions as SLPs as far as how can technology help to support a conversation for someone living with PPA or PPAOS? And that's really going to be different for every person. Some people are great candidates for using high-tech communication devices or on the smart tablet or phone, while others are not. If they're not motivated or not comfortable using those tools, communication partner support is going to be very important in that consideration. So that's something that an SLP really needs to assess. Also, thinking about non-language cognitive deficits, sequencing and attention and auditory comprehension difficulties are going to increasingly become challenging. Can that individual, on an ongoing basis, that might change in terms of how they can use technology and the level of support that they'll need. So I always mention that, but certainly we'll take a look at how we might use technology as a compensatory tool as well. So certainly in this process of creating our different visual aids, I love to create that inventory of what are those personalized gardening vocabulary, maybe some corresponding pictures to use in all of our interventions. So this is often a conversation with the SLP and the person and their family members, just having that conversation in this case about what types of flowers or plants do you grow? What do you do in the garden? Who do you garden with? And we're creating this list of different really key words that now we can use in different types of exercises or in visual aids, communication book, a communication device. Um, and so I'd like to often start with that. Great intervention, personalized intervention is script training. So in this case, how can we really practice at the sentence level, the conversation level, over and over again? We practice, a script to tell people about the garden, and then certainly bringing that visual aid, perhaps, to that FaceTime chat or getting together with friends and family as well. And sometimes, again, those scripts are catered towards that person. So maybe going shopping, practice that conversation to talk with someone at that gardening shop for what kinds of plants they would want. So all things that are very person-centered. And in terms of making communication, pictures with captions, just creating these collaboratively in the sessions, having the individual help to pick out pictures, what words are the most important to them. As we mentioned, those high-tech visual communication aids, there are many different apps that may potentially be helpful to support language and speech for someone living with PPA or PPAOS, in addition to apps that are developed specifically for people living, with the condition. And so that's where, thinking about making, with the collage app, the pictures and the captions, or, Pinterest or the photo stream, making some folders, just all, working with the family to determine those things. And then another, again, we're always thinking about how can we integrate really in all aspects of life, right? And activities, different types of activities that might focus upon that hobby or perhaps indoors in addition to outdoors. And so a Montessori approach has a set up environment and then some visual aids perhaps to show pictures and captions and the steps for making pressed flowers, or perhaps planting some seeds. And so really going through those steps and having those meaningful activities and conversations at home or with others. So that's just an example of a goal and how we might use evidence-based interventions to support that person-centered goal. And just another resource that might be helpful for families if you are wanting to provide them with some obviously AFTD, many other organizations. The National Aphasia Association does have support groups for people living with the diagnosis, care partners, and website resources. So, with that, I am going to pass this along to Anna here.
Reminder. Let me go ahead and share my screen if I'm able to. There we go. Okay. I'll be talking a little bit about some considerations for assessment and treatment for individuals who speak more than one language and present with primary progressive aphasia. So here's a little roadmap of just a couple of things I'm going to touch on today. Just to get us started, I'll talk a little bit about what I mean when I use the term bilingualism, because we might all have different ideas of what that means. I'll talk about a couple of myths that we've been working on debunking surrounding approaches that we use for assessment and treatment in people who are bilingual. Then finally, I'll talk a little bit about a care partner program that we've been developing for bilingual care partners. So what do I mean when I say bilingualism? I'm here talking about the repeated activation and use of two languages. And something that is a common misconception when we hear this term bilingualism, oftentimes people think that means you have to be equally proficient in both of your languages. But oftentimes, and the majority of people who speak more than one language have a dominant language, so one language that's quite a bit stronger than the other. Why is bilingualism relevant? Well, we know that more than half of the world's population is bilingual, and bilingualism is indeed the norm worldwide and is on the rise in many contexts, including the US, which you see here in this blue graph, this blue line on this graph, rather, increasing from the 1980s to present day, showing that bilingualism is indeed on the rise in the context of the US. However, when we go to the literature as speech pathologists or other healthcare professionals, or if you're even an individual, living with PPA, you might look for resources and find there's really not much available targeting and that has focused on individuals who speak more than one language. So we see that English tends to be the language that's the most represented in the study of PPA. Becky mentioned a couple of reviews that support treatment research in PPA, showing that speech pathology can be very useful for individuals living with PPA. And there's many different tools that Becky just mentioned that we really have in our toolbox to support communication. But of all of the studies that have been published to date, there's only 3 that have focused on bilingual speakers. So we're at a bit of a loss for thinking about the best way to approach and provide support to people who speak more than one language. When it comes to thinking about representation more broadly, the treatment literature has predominantly been conducted in the United States of America. Many of the studies actually require that individuals are native speakers of English. And this is important because then the evidence we have as a field of speech pathologists is really limited to individuals who are speakers of English. And there's very poor representation when we think about ethno-racial representation as well. So we were curious to hear from speech pathologists about what they're doing clinically when they work with bilingual speakers with PPA. And we developed a survey, and we had 192 speech pathologists respond across 27 countries. And they reported the following: that they're most likely to provide assessment to individuals with PPA in the dominant language, again, thinking about that strongest language. We also saw that there's very limited access that they reported to assessment tools that might be useful for bilingual speakers. And so they tend to rely on informal methods when working with individuals who speak more than one language. And then finally, this was enlightening to us to learn over half of the SLPs had received less than 2 hours of education on the topic of PPA and bilingualism. So focusing in on this one finding from the survey that SLPs are most likely to assess bilinguals in their dominant language, I want to talk about this first idea and concept that comes up quite frequently. This idea being that testing or providing an evaluation in the dominant language is the best thing to do. And I'll just say that from our work, we actually see that the non dominant language or the weaker language is the most sensitive to detecting and helping to differentiate the type of PPA someone might have who speaks more than one language. However, of course, when we're thinking about assessment more holistically, of course, we want to get information about both languages because people become bilingual because they have a need to use both languages. So we tend to see that the dominant language is more preserved. And so I think we can say that we've busted this myth that testing in the dominant language is not the best practice. Moving on to the next notion that comes up quite frequently is that individuals should be treated in their dominant language because it's their strongest language. So what I'm showing you here, if you kind of look at this figure across the x-axis, what you'll see is time. So before and after individuals have received speech therapy who are bilingual, and at some follow-up time points as well. And we're seeing how beneficial the therapy was for them, right? So the higher on the graph, the more beneficial. And here in blue and green, I'll just point out that this is how much individuals improved in their dominant and non-dominant language from a restitutive intervention. We see this for script training, one of the interventions Becky mentioned earlier, as well as naming intervention. What you might notice is that these blue and green lines representing the dominant and non-dominant language show a very similar effect, right? So we actually see that there's significant and equivalent improvement in bilinguals' dominant and non-dominant languages. So once again, I think we've busted this myth, showing that really individuals who are bilingual benefit from intervention in both languages. And as clinical professionals, this means that you should find creative and collaborative models to support both languages, again, because people become bilingual out of a functional need to use both languages. And if you're a bilingual person yourself living with PPA or a care partner, this is where you can really advocate for getting support in both languages. Okay, I'm going to transition ever so slightly and just talk about the development of a psychosocial education group for Hispanic and Latino care partners that we've been developing over time. We know that there's limited but very promising evidence supporting the use of psychosocial education and support groups for care partners of individuals with PPA. But there's a significant need for having culturally competent services that are provided to individuals for Latino and Hispanic individuals who tend to be at a higher risk of developing different types of dementia. So our goal was really to develop and capture the benefits of a bilingual support group program for these care partners. So I'm just showing you an overview of what this program looks like. We have a focus group where we invite care partners and individuals with PPA to come and talk with us about what they would like to get out of the group, what kinds of topics do they want to have covered, what kind of education could we potentially provide, what kind of content do they want, right? And so that's really the purpose of that focus group. We then actually have the program itself that we've developed based off of the content. So we've co-developed this with the care partners to ensure that the material is what they really want to learn about. And we also include a text message based augment called Ayúdame, which I'll show on the next slide, which we're hoping in the future we can provide more widely. And then in the second phase, we engage in something that Anna is going to talk more about, which is really this tailored communication and conversation training that occurs with the care partner and the individual with PPA. So we have both of those components as part of this program. And this is just showing an example of how this text message-based platform works. So individuals can text this phone number, and if they want to get on-demand support, kind of learning about different caregiving topics that were driven by the focus groups, then they can kind of go through these options and get some more information. And just very briefly, I'll say what we're seeing as a result of participation is very in line with some of the other work that following participation in this program that has really been co-developed with these care partners, we see reductions in stress, and we also see increased dementia knowledge, and they also report using additional strategies when it comes to conversation. And just to kind of give some general considerations that hold true when working more generally with culturally and linguistically diverse communities with PPA, I wanted to touch on just a couple of guiding kind of principles. We know that there is incredible variability within any cultural group, not just between cultural groups. And that ethnographic interviewing is a really powerful tool for speech pathologists. This really shifts the SLP away from assuming that they might know what kind of information or goals would be the most relevant for each individual with PPA and their families, and really engages in this practice so that individuals really get to guide themselves what they would like to get out of therapy, as well as their priorities. So really focuses on tailoring and individualizing intervention. So with that, I'll just conclude on a couple of things that I touched on today. We know assessing in only the dominant language is not sufficient. Again, I've said this a couple of times, but people who speak more than one language really have a functional need to utilize both languages, and so should be supported by speech pathologists and other rehabilitation specialists in their functional use of both languages. We also see that individuals show very large improvements in both of their languages. And so this idea that the dominant language is the most likely to benefit from intervention simply is not true. And we see that psychosocial education and support group programs are really beneficial to care partners, especially when the content has been co-developed by the care partners who have a lot of experience. And we see this reduction in stress, increased dementia knowledge, and increased use of using communication strategies. So with that, I can come back towards the end and share this slide to share our contact information with all of you. And I will let Anna take over.
Thank you very much for having me. And sorry I wasn't able to be with you in between the two prior speakers, Becky and Stephanie, as scheduled. It wouldn't be a webinar without tech difficulties. So I'm going to share my slides and hopefully you'll be able to see those slides okay. So, and I should also say a thank you for the generous introduction at the beginning. So I'm a clinical speech and language therapist and research speech and language therapist in the UK. And I've also worked for many, many years. 5 years, I actually also worked in Australia in the same field. And what I found is that when I work with people with primary progressive aphasia, in fact, with any type of dementia, was that they didn't always know the breadth of the role of the speech and language therapist. And indeed, we've found the same in the research studies when we've talked to people with primary progressive aphasia and their family members. They've said things like, I have a lovely quote. Somebody said to me once, going to a speech and language therapist is like going into a chocolate shop with a blindfold on. It must all be really good. I just don't know what you do. So I think this is a really great opportunity in this webinar to share with all of you health professionals and talk about the range of our roles so that when you do meet someone with primary progressive aphasia or any type of dementia, that you can share with them the range of roles that we have and the kinds of things that we can do to help people in their lives. And with that, I thought I should emphasize here that actually what we're talking about in relation to primary progressive aphasia has relevance for people with all types of different dementia. We know that when people experience dementia, they experience and interpret it through the lens of interaction, whether that is somebody using repetitive questioning whether that's somebody forgetting an appointment and asking about the appointment, repeating a story, stating something that perhaps is socially not so acceptable, or having a difficulty retrieving a word, a sentence, using the wrong grammar, or articulatory difficulties. These are all things that people interpret through their interactions with another person. So what we're telling you here is really valuable across the huge population of people living with dementia, but particularly relevant to people with primary progressive aphasia. So how I'm going to hone in on primary progressive aphasia. How is conversation affected when somebody has primary progressive aphasia? Well, we know first off, and perhaps most obviously, this is something you've all seen, that people with primary progressive aphasia and all types of dementia feel frustrated by their communication difficulties. It can be very frustrating when somebody has the intention to convey a message and they can't find the right words, or they use the wrong word, or the speech sound came out wrong. But it can be equally frustrating for the people around the person who perhaps don't know what to do to help. People with PPA might feel left out of conversations. They might find it hard to keep up. So often it's really common that people say to me, they find group interactions particularly difficult right from the very early stages of their disease trajectory. And they find it hard to follow what people are saying, keep up with the grammar, or find the right slot to take their turn. They often report finding it quite upsetting, but they also often report the effort required to interact can make them feel like they can't always be bothered, whether it be communicating with their immediate loved ones they want to, or in a group. It just can be so much effort. Similarly, I mentioned family members often tell us they feel really frustrated, they don't know what to do, they start changing the way they communicate. And they often start talking about the fact that their interactions don't feel like they're the husband, partner, adult child of that person. They start saying they feel like the carer or the parent of that person. And that can then change the relationship in itself. People often tell us that family members say it's so much effort for them as well. They can't be bothered either. And the balance of conversation and interaction can become different to what it was before. So what I wanted to emphasize, however, so that's what people tell us about their interactions, but the majority of the research literature is focused on people in English-speaking countries, as perhaps somewhat illustrated by what Stephanie was saying. But one of the things we wanted to know is, in our research, is what do people living around the world with PPA say? So we recently undertook a research study on asking people with PPA and their family care partners what they'd most want to change about their communication and the way primary progressive aphasia affects their lives. And we asked them in different groups around the world to share all their ideas about this in response to this question. And then we asked them to rate the most important things that they'd shared. So what are the most, you've got all these things you want to change, but what's the most important stuff? And we collected responses from 17 countries worldwide, and we aggregated, so we added those up. And I just want to highlight that actually the thing that came out of this data, of this data from over 100 people with PPA, over 100 care partners, was that people most want to be able to talk and participate in conversations with family and friends. So actually that's, we're going back to that very first slide I showed you, that's one of the things that we can do through all of the things that Stephanie and Becky have mentioned. We have a really important role in supporting people to talk and participate in conversations with family and friends and maintain those relationships. So if we look at these in a bit more detail, I just thought I'd hone in on the individual countries. And what we found was, by looking at the individual things that people across the world highlighted, so let's hone in on America. These three items on the left from people with PPA, and the items on the right are from communication partners. You can see there's data from countries like Norway, India, Australia, the UK, Greece, Turkey, Italy, We got some data from Chile and Brazil. We found that, and I've coded these in colors, that actually almost everybody was talking about having some certainty around the future in what they wanted to achieve. And they wanted support from the people around them. So not only is the absolute top item, the thing that we added up and scored as the highest was having conversations, but in fact, almost everything they talked about was around certainty and support from their communities and their family and friends. So how can we achieve that? We've already talked about some specific things, but I wanted to talk briefly about communication partner training or conversation partner training. Now, in the UK, we developed something called Better Conversations with Primary Progressive Aphasia. Better Conversations with Primary Progressive Aphasia is an intervention protocol that we've developed and we teach speech and language therapists to use. And what we do in that intervention is we look at the conversations people are already having, and we support them to identify what they want to do more of or less of. And I'll give you an example of that. So, for example, it's not uncommon that I see family members asking their loved ones test questions that they know the answer to. So questions like, what is my name? What did you have for breakfast? What is the color of my t-shirt? And they're often things that people start asking, and they're kind of questions that we don't see in typical conversations. They're questions that teachers ask or perhaps parents ask. And so we show them videos of those, often show them videos of their own interactions and help them identify how they can do less of that type of questioning and perhaps how they can balance the conversations to support people to generate a topic or ask a more open question or give a comment instead of asking these often quite bombarding questions. And this is what people say to us about this type of training. They say things like, I thought my husband only had difficulty speaking, but I know now his understanding is affected. So it helps people see the breadth of the person's needs. People say to us, oh, I've learned not to switch topics as much. I've learned to use supports, tools, non-verbal strategies. Often somebody once said to me, I learned to see rather than just to listen. So looking at people's physical and non-verbal behaviors. People say we've gained insight and learned alternative ways of communicating and relating. Somebody once told me, I thought my partner had fallen out of love with me, but as a result of your training, I really understand that his conversation behaviors, the things that were happening in the conversation were actually things I could change and think there were things I could do. And now I understand that he loves me just the same and we can keep having better conversations. People said what we've learned is if we practice, doing conversation is hard and we need to practice, and the partner can help the person with PPA come back into the world of language. I think that's really powerful. So just to let you know, we haven't just asked people what they think about this. We've also done research in this field, and we know that we can change what people do in conversations. We've measured it. We set goals in this intervention and people report that they've achieved or overachieved these goals. People report improvements in conversations about actually how to have these conversations. And as a consequence of this intervention, people have reported to us that the impact of PPA is lower on their lives. I just wanted to flag as we come to the finish that Becky, myself, and Stephanie are all members of the International Speech and Language Therapy Pathology PPA Network, which is a group of speech and language clinicians and academics who come together to try and maximize our resources to do more research and develop resources in this area. And we do have a resource page, you can see that on the far right, that if you wanted to steer the people you work with towards or look at yourself, we've got lots of handy resources. And from this network, we've developed an international PPA awareness day. The first event was earlier this year, and this is going to become an annual event in the future. So with that, without further ado, I'm going to finish my slides and stop sharing and hand back over to the rest of the team for what I believe will be the Q&A.
Yes, thank you, Anna, and thank you for inviting our other presenters back. That was quite a whirlwind and a lot of information. Forgive us for asking you to collapse that all into 1 hour, but I think you all did a wonderful job. And thank you to our audience for your understanding of our technical difficulties. We actually have 4 different time zones represented in the people on the screen. So it always makes things more fun and interesting. So we have a number of questions that have come in, and so we're going to launch into those now. And I'm first, what I'm going to start with, one of our very early questions, kind of related to, first off, often people with primary progressive aphasia also develop symptoms from the other FTD disorders. And Becky, I know you talked about this a little. So one of the questions I would ask, one of the behavioral symptoms that might impact therapy and success is apathy. So if any of you could comment on how you support individuals and caregivers through an apathetic response. And Anna, you raised your hand, so I'm going to pitch it back to you. But then just know, for all of you, there'll be a follow-up about the complications of people with other FTD disorders that ultimately develop uh, aphasia symptoms. But let's start with PPA diagnosis first, and then a broader development of other FTD symptoms. Anna.
Sure. Speaking, apathy is an excellent example. And I think one of the key things I find useful is to help the people around the person understand the symptom. Because I think often people around the person may interpret the symptom as a lack of caring, a lack of love, a lack of effort, laziness. So I think one of the key components that I always start with is thinking about how can we support the person and everybody in that person's extended family to understand those symptoms and how that they may impact on interaction more broadly, and then what they can do from in terms of bringing in just not just verbal prompts but non-verbal sensory stimulation that can support the interaction in its broadest sense, reducing distractions, all of those components.
Thank you.
I was going to say, yeah, absolutely, Anna. I do exactly the same thing. And sometimes with the communication partner training, an individual can use some of the communication aids or participate in activities, but it will just letting them know that they will need to take an active role
Yeah.
in helping to prompt the use of the different communication aids, because there may be a lack of initiation in using those, and creating a very specific schedule that so it's almost automatic. Oh, at this time of day we go for a walk, at this time of day we go out with friends, and so that way it's almost anticipated. So perhaps, again, educating that this is part of the disease, the apathy, but we can have some ways to try to help stimulate participation. Absolutely.
And certainly the other symptom that's very common, and you also mentioned this, Becky, early on, is challenges with executive function, and being able to do a task with multiple steps, or recalling those steps in a specific order. And I'm going to assume that that's, to some extent, working with the primary caregiver. And I think one of the issues that's highlighted in the questions is it's not just about working with the person with FTD and their primary care partner, but then you've got that wider network of caring individuals, which may be family members or friends, or if the person is being assisted by home care or hospice or assisted living. So I think let's transition to that. And if any of you have any thoughts on what helps families, either the person with aphasia or the care partner, to help train others. And I realize I skipped one of my questions, but let's go with that one.
Do you
So
want to go first, Becky, or shall I? I can see Becky and I are both chomping at the bit to answer.
Sure. I can start off, and I think all of us can recognize that there's so many barriers that we're facing when it comes to people living in memory care communities or care facilities. I know there are different terms. And in terms of how do we train a staff where people, often the caregivers, aren't well trained. Salaries are often very low. They are overwhelmed with so many individuals that they have to care for at one time. So, how can we train them, especially if they have different shifts and different people are working with the individual, in terms of helping them to communicate and training them on those different strategies? And so, there is research in this area, growing amounts of research, and it really, SLPs are a critical part of that team in that care community, in terms of training, different ways of training. Perhaps like in the individual's room, I'll set up a communication station that will have in one place like all of their visual aids. Hey, here are the strategies you can use to communicate with them. Here's who they are as a person. Here are, different ways you can, if they have behavioral difficulties, here are some suggestions. Here are different activities they can enjoy. We have those set up in the room, or here are strategies to get them to participate perhaps more easily in other activities around the community. So there are many barriers, but I think with working as a team, and with the family and with the individual, certainly we can try to promote the ability to communicate and participate in meaningful activities in that type of community. Anna, I'll pass it to you.
I think that when we do our intervention work, we often ask people how they would like to communicate and the messages to the people around them. And I think, as Becky's saying, it's so important. And I've had people making video recordings that they share with other people. We make bespoke video recordings, or make a bespoke page in their communication book, or we might make a bespoke or use a generic, like the ones that AFTD have, a card that includes some, like a wallet card or a lanyard card that has some specific tips on there, or even a script that people can use to tell people how to communicate with them. And I think that that's often a really useful way of sharing things immediately. I often work with children and adult children, younger children, friends. These kind of interventions work really well with those people. And we often do work with paid caregivers right up into the end stages. I've found that there's an intervention approach in the UK titled intensive intervention, but it's, in the broadest sense, it's very similar to what I've described around looking at people's interactions. Interactions don't depend on words. Interactions can be non-verbal as well. And paid carers support family caregivers to use non-verbal interaction. And I have to very briefly tell you a story of a client who it was the client's husband. He rang me a couple of days after his wife passed, and he said, the last thing my wife did when last time she opened her eyes, she held out her arms, and I knew she was saying goodbye, wanted to say goodbye to me. And I only recognized that because you taught me to look for her non-verbal communication, and she was able to communicate with me right up into the end, and you showed me that. Thank you. And that was through communication partner training work that we done on and off over many years, not continuously, just on and off over many years, dipping out of speech and language therapy, in and out.
Thank you for that response, in-depth response to that question. Let's go back to the question I left hanging, which one of our attendees acknowledged, which is definitely true, that people with a diagnosis of BV-FTD originally, or CBS, PSP, may develop communication challenges, like a person who originally has a diagnosis of PPA. It's a spectrum, and with ongoing neurodegeneration, other symptoms beyond the initial diagnosis can start to occur. So do any of you have recommendations? I would think that the person and the primary care partner, unfortunately, really need to advocate for noticing those changes as the disease progresses and talking with a clinician about a referral to a speech language pathologist. Would you agree with that, or any other thoughts on that?
Yeah, agree. Absolutely.
Yeah, I completely agree. And it really is a spectrum. And we can definitely find ways to support individuals who have all different kinds of communication challenges. So it can range from individuals who, have memory impairment accompanied with communication challenges. There's a lot that speech pathologists can do to help support communication in that framework. Also, with individuals who have changes in terms of speech production caused by things like PSP, right? There's a lot of different intervention
Mm.
options that we have available that might look more like augmenting communication by using some of these nonverbal gestures that Anna was mentioning, but also the communication books that Becky mentioned earlier today as well. And so there are many different tools that are available, but I think it is really pointing out and explaining and having that advocacy present to kind of say, I'm noticing these communication changes in my partner, even if it's not the thing that's the most noticeable, maybe to the healthcare provider that they're working with.
We have a lot of questions. So I'm going to acknowledge for our audience, our presenters were willing and happy to stay a little bit beyond time. So we're probably going to go for another 3 to 5 minutes. If you need to leave us, audience members, we totally understand. I think pulling from a number of the questions, there were some questions about, like, after the initial assessment and the speech language therapy treatment plan, what's the next interval like? Is there something that a person with PPA or language issues and their care partner should automatically think, or maybe when something specific happens for that next assessment? And added to that, people are asking about when people have very limited language abilities, maybe can speak only 1 or 2 words. Is SLP intervention still helpful at that point? So let's talk about the when along the way and then later in the stages. And anybody want to start that one for us?
I can speak to here in the US. Because certainly the ability for us to see individuals, in the US, we have Medicare for people who aren't 65 yet, may not have access to Medicare, and so are relying on private insurance, which may or may not, support. Uh, Speech therapy reimbursement. But in general, I find that after that initial evaluation, certainly, whether it's once or twice a week, for several months, others may take a little bit longer, but then once we feel like an individual and their care partners really have a sense of, okay, we've got these strategies down, we've generalized them to our daily conversations, activities, we feel like we're at a good spot. Okay, let's take a break, but please reach out to me if anything changes. Things are getting a little bit harder. And so then at that point, we can come back in. So that really varies for each individual. I think another barrier is that some SLPs may not know how or be familiar with how to write reimbursable goals for people with a progressive condition. And so that's where we do come into, well, there's nothing else I can do for you, perhaps, or insurance is not going to reimburse this anymore. But that's where, if we're using the person-centered goals and we can really demonstrate functional progress towards those goals, we can show insurance that yes, they are making progress. They just have to be realistic goals that are focusing on things that are attainable. And lastly, to answer the question, is there ever a point where speech language therapy isn't appropriate or can't help anymore? Um, no, absolutely not. It's going to look different as things go on, and for every individual, if they are nonverbal or if comprehension is so difficult that they can't comprehend conversations very well at all. Every individual and their family members has a unique kind of toolbox, whether it's gestures or using communication aids or trying to use videos to help communicate. And Anna and Stephanie, you can add to this, but it really is going to be unique. And also, what are those other symptoms if they don't have insight into any of their challenges? If they have apathy, if they have behavioral challenges, we may be relying more on that care partner to provide cueing and the supports needed as things progress, and therefore, again, all the way, throughout the progression, absolutely working with an SLP is critical. It just might look a bit different as things go on. So that was a little long-winded answer, but Anna, Stephanie, I'll hand it over to you for any other input.
I was just going to add a sentence. We are all members of a group who published a best practice principles for clinicians, speech therapists working in this field with representation internationally. And one of the quotes there was that speech and language pathologists should walk alongside the journey, alongside people and families with PPA from beginning to end. And I think that's probably a really important kind of overview to take. And to circle right back to Becky, one of the first slides that Becky presented, is that a lot of the research on the role of speech language therapy is based on stroke aphasia or acute onset conditions. And what we really need to reconceptualize, and this is why this research that we're all doing and these kind of talks are so important, because people with PPA and their family members and all the people around them can benefit from speech and language therapy from the entire, throughout every moment on their journey, and in actual fact. And we need to show that, so that commissioning models or funding models throughout the world, which are all different, of course, but so that we can make those adjustments to ensure that people can access support at the right, at the right times throughout that journey.
So I'm gonna ask one last time, any other comments? Unfortunately, we have a lot of wonderful questions. I've done my best to try to collapse some of them. We won't have time to answer them all, but any last comments from any of our presenters?
I'm happy to, if you have a record of the questions that we didn't have a chance to answer, I could put those at the end of my slides that you'll be sharing the PDF with everyone, if that would be helpful. Certainly those are very specific situations, it might be difficult to speak to those, but I'm happy to do that if you have record of all the questions.
I believe that's the case, Becky. So I appreciate your volunteering to follow back up. Let's connect on that offline. But
Sure.
thanks for stepping in and volunteering that. And so thank you, speakers from around the world. This was a really engaging and interesting presentation, and we probably need to do this again sometime in terms of all the information that you shared and the interest that our audience has. Thank you, audience, for your questions and also your positive feedback. There's a lot of words of appreciation for our presenters and speakers. So we are going to move on and say that, if you have any other questions that we're not able to answer, we always encourage you to reach out directly to our helpline, either by calling our toll-free number or by sending us an email at info@theaftd.org. And then we also want to acknowledge the FTD Disorders Registry, which is an important resource that is helping us to hear from those living with FTD disorders, sharing their lived experience, really guiding and enlightening researchers. Families can learn about currently recruiting research opportunities and choose to share some of their own experiences. And healthcare professionals are able to join the registry as well to learn more about what's going on. And there is a lot that's been happening over the last few years in terms of FTD specific research. So this concludes our webinar. And we will be sending you an email tomorrow again with the continuing credit submission process, and wish you well. Thank you so much.